This is fine. This is fine. This is a poor substitute for therapy, but an excellent substitute for other podcasts.
We're not like other podcasts.
Join us as we find the answers to the universe's biggest questions like, is butter a carb? Does crying burn calories? And what the fuck am I doing with my life? We're here to be your part-time therapist, astrologer, concierge doctor, and fairy godmother. Do you need someone to validate you today? Cool. Come on in. We're fine. This is fine. Hey, happy holidays, fam. Half of my personality is Christmas time, and usually I begin getting in the spirit on October 1st, but I've been really practicing some patience and delaying that until midnight on November 1st because I'm in a growth mindset and really working on myself. Anyway, today's episode has literally nothing to do with the holidays, but I'm just in the spirit and I want to share that energy. Go get a gingerbread latte and think of me while you sip it. In a non-creepy way, of course. Moving on. I hope you're fine. I hope you're actually fine and not sitting in your kitchen while the house around you is on fire. To be honest, I haven't been 100% fine, particularly when it comes to my hormonal health, and not to unload on you or anything, but we're going to be talking about that more today. Women's hormones, hormone health, and menstrual health are huge topics in the wellness world right now, and frankly in general, which is great to see given that it's yet another part of our everyday lives that was made to be such a taboo. Given that all humans have hormones, more than half of us on the planet menstruate, and about 10% of us or more have PCOS, this feels like a pretty far-reaching, in fact, universal topic. This is probably extremely unhinged, but I brought in my own OBGYN on the show today to talk about all of those things, hormonal health, including imbalances, menstrual health, and PCOS. She has known me since I was a teenager and has helped me navigate some serious health challenges, but is also simply a brilliant physician, surgeon, and expert in this field. Dr. Catharine Marshall, MD, board-certified OBGYN. She did her internship and residency at USC, by the way, fight on. She's known for her laparoscopic surgery skills and is a member of the Scripps Minimally Invasive Robotic Surgery Program. Because she is such a wealth of knowledge, we're going to break up this interview into 2 episodes. Today, we'll go over Hormones 101 and the concept of hormone balancing. What does it mean to balance hormones? Next, we'll get into the episode with more specific questions from listeners, including questions on hormonal birth control, cycle syncing workouts, fertility, and more. Okay, welcome, Dr. Marshall. Thank you so much for being here with us in the studio today. So excited to have someone here with me in this room. Thank you for taking time out of your busy schedule to educate our listeners and chat through some questions and concerns. We always like to start out the episode by a little check-in. Are you fine today?
Very fine.
Okay, good. We started out with some Stella Snuggles. I feel like that always puts people in a good spot.
Oh, for sure. Oxytocin. Talk about hormones.
Right? Yes.
That's a good one that we get from our pets.
Yeah. So that's a perfect segue, actually. Well, I guess before we get into those specific hormones, speaking of a perfect segue, let's actually talk about how you got into your field. What drew you into women's health?
Yeah. I actually was a history major in college.
I didn't know that.
And I did the pre-med prerequisites, but I actually did a lot of sort of women's history as an undergrad, sort of accidentally, and also because it was absolutely fascinating, this secret history of, women's cooking and witches and what a broomstick really was and things like that. And I didn't realize I was sort of headed on that trajectory. I got into medical school and I thought I'd be a pediatrician or a cardiologist because I loved cardiology, the whole physiology and things like that. But I think in life you kind of do what you're good at and you get the positive feedback and then you end up going in that direction. And for me, even though I was sort of a very shy person when it came to women's health and not a obviously vocal person, interested in that, it was sort of where I landed in medical school. My first delivering a baby, as a third year, I broke down in sobs. It was like the most amazing experience. And so I kind of thought, yeah, this is this is the right way to go.
That's
So,
incredible.
yeah.
And the rest is history.
And the rest is history.
Literally,
Yeah.
women's history.
It is.
That is so, I actually didn't know that. And which is funny because I feel like we've had so many chats over the years. So
Yeah.
you learn something new every day about people you care about. This is great.
Well, and I also want to put out there, I know, a lot of people feel like they have to do super biology and super scientific backgrounds to get
Right.
into medicine. But we're lucky in the United States, with the 4-year colleges, we have a chance to sort of broaden our horizons. And, a lot of people going to medical school are, psych majors or, history or
Right.
journalism. There were all over the field. So
That's so, I actually didn't know that. I mean, obviously I
Yeah.
didn't go the medical school track. I think I probably told you I was in neuroscience for like 15 minutes. And I was like, I can't do blood. Bye. And that's how we ended up here. What could have been. But I love that you have that historical background. I think it adds, what I imagine, a lot of context into how you practice.
yes, yeah.
So cool.
I think, it's helpful to be able to pull in context, like
Yeah.
you said, and to have other, resources in journalism and whatnot that in history that help understand things like hormones.
Right. Okay.
Yeah.
So perfect. Let's get into those hormones. I bring this up because, for context for people listening, this is a really big topic right now on social media. And especially within women's health, there's a lot of ambiguity, especially when it comes to hormones. And I guess there's ambiguity not even just on social media. I think that not a ton of people know a ton about hormones. And hormones aren't just your sex hormones, your female hormones. Let's talk about the difference between the sex hormones and then I think, is it 50-ish hormones in the human body, like the rest of them?
Right. Yeah. Well, I'm most interested in the female hormones,
Of course,
and,
yes.
and the big ones that come into play with puberty and the different phases of the woman's life. There's, we sort of divide up the hormones into, chemically, biochemically, what are they? Are they the peptide hormones or are they the steroid hormones? Obviously, steroids, they're derived from cholesterol.
Mhm.
So, you can't be on a zero cholesterol, diet when you're a child and, and have good levels of steroids. And
Right.
so
In order to grow.
exactly,
Okay.
your brain needs them. They're really essential. So essentially, I'm most interested in the hormones that come from the ovary.
Right.
In women that sort of get turned on by the hypothalamus, which is part of the brain, and the pituitary gland, which is also in the brainstem. And so there are these, triggers that happen, and basically peptide hormones from the hypothalamus go to the pituitary, and then they trigger a cascade from the pituitary. Hormones LH and FSH.
Mm-hmm.
which-
Luteinizing hormone.
Exactly.
And follicular stimulating hormone.
Exactly.
Okay.
So these pulses from the brain, hypothalamus, then turn that on, and then the FSH and LH turn on the ovary.
Okay.
And there's a certain diurnal variations in the way the pulses, and there's basically a systemic hormone like this acts not on just from one organ to the next, but all the way across the whole,
Like the rest of the body.
The rest of the body, exactly.
Okay.
So, you go through puberty, you start to have estrogen levels rise, ovulation starts to be triggered, and you start to get menstrual cycles.
Right.
And naturally, we have estrogen and progesterone made by our ovaries. There are several different types of estrogens. The one that's the most important and the most active is called estradiol. Diol is 2. There's also one called estrone, and there's one called estriol.
Oh, wow. Okay. So there's
so
I'm like, oh, wait, I got to take
That's
those.
just estrogens, right?
Estradiol, estrone,
Uh-huh.
and what was the other one?
Estriol.
Estriol, and that's under estrogen.
Yes.
Okay.
So they all stimulate estrogen receptors, but to varying degrees.
Okay.
Estrones sort of the naughty one that actually is made in adipose. People think, my fat just sits there, but actually it creates estrone.
Wow.
And this is, we think, part of some of the having abnormal hormonal things go on is that if you have too much of this estrone, you can have increased risks of things like in your lifetime of uterine cancer, ovarian cancer, breast cancer. And that it can have adverse effects on fertility as well.
Wow. Would the inverse be true if you don't have enough adipose tissue? It could affect your cycle because you don't have enough estrone?
Yes. And again, that gets to the cholesterol, and you need sort of like the basic building blocks to make those hormones.
Right. So it sounds like it's in like a delicate balance at all times.
If you're very severely caloric restricted, like in anorexia, yes, there will be problems with the maturation of that hypothalamus, pituitary, ovarian axis. If you're, let's say, in a worn, torn place and you're not getting calories, it may be very protective to have your ovulation turn off. You certainly don't want to get pregnant in the middle of, an emergency and things like that. So it is sort of a self-preservation thing as well.
Interesting. Okay. Yeah. I'm thinking of so many different things of like overexercise or stress and how that, obviously all of those things impact a myriad of hormones. This might be one of them that could directly impact your, I'm guessing, fertility or cycle, et cetera.
Right. Exactly. That being said, it takes quite a bit of exercise to, make these problems. There are plenty of elite athletes who have absolutely normal cycles.
Good to know.
But if you are, an athlete with not very regular cycles, although the low hormones may be very sort of egocentric, may be like, enjoyable, et cetera, long term, some of the high school athletes who are exercising so much that they're not getting their cycles may have issues with lower bone mass, lower, things like that. And then sometimes it can carry on to issues with fertility down the line if that hypothalamic, pituitary, ovarian axis is like not sort of given the juice it needs during adolescence and early adulthood.
Interesting. And so that's stuff that, a patient or an individual may not even be aware of by the time they make it to your office.
Yeah, I've had patients come in and they're so offended that they were told to gain, 5 or 10 pounds when they were trying to get pregnant on their pregnant journey and things like that. And it's not a, social judgment. It has to do with
your health,
helping your health and helping, like I said, have the right amount of hormones. We're kind of mostly on the other end of that, though, where we're sort of overfed in our society right now. And so it's a tightrope to walk, to exercise, without doing it too excessively and to restrict your calories, but not too much.
I saw this meme. I'll have to send it to you. It's one of my favorites. But it's like, never eat sugar. It's so bad for you, but also your brain needs it. And drink water, but not too much. And walk, but don't run. But actually run because you need to burn calories, but not too many calories. And I feel like that's like, again, we keep coming back to this very delicate balance. Like our bodies are in kind of a delicate balance at all times, and specifically with hormones, which I think is perhaps what's feeding into this whole trend that I've been seeing a lot of on social media, the term balancing your hormones.
Yes.
And I feel like that is a very, very broad term, especially because, as we pointed out just a bit ago, there are many hormones in your body. The people who are speaking to this topic don't necessarily indicate what they're talking about. They may infer that they're talking about estrogen, progesterone, LH, FSH, but other hormonal imbalances can cause things that have nothing to do with women's reproductive health. I mean, everything has something to do with something, but I'm talking like you can get diabetes from a hormonal imbalance. You can get hyperthyroidism from a hormonal imbalance. There are a lot of other hormones that have nothing to do with this particular topic, but it's been kind of woven into the menstrual health and women's health narrative. So I feel like this is a really important thing to clarify from a medical perspective, that hormone balance is pretty general, right?
Yeah. So from a broad endocrine, view. When someone says that they fixed their diet and balanced hormones, a lot of times I'm thinking they got their insulin levels under control.
Which is a hormone.
Which is a peptide hormone made in the pancreas.
Okay.
And it's an important one. We need it for sure. But the problem is when you have foods with very high glycemic indexes, basically they shoot the sugar up really fast.
I'm looking at my yogurt bowl with like fruit and honey in it right now. I'm like, yeah.
But fruit is okay. Honey's probably, yeah.
It's like a nice sugar, right?
They're natural sugars, for sure. But, eating an apple that actually has like, lower glycemic index than a lot of other foods. But the berries are also, very good that way.
Yeah.
And basically, a Krispy Kreme, which, once in a while is like so delightful. What it does is it makes your insulin spike like crazy.
Right.
And insulin is one of these hormones that basically tells our body to do things we don't want. Like it says, oh my gosh, we gotta, store some fat.
Right. And you're like, no, thank you.
if all, believe it or not, if all you were to eat, it's not just calories in, calories out. It has to do with what those calories do to your hormone levels.
The instructions they're giving.
Exactly.
Wow.
So if you eat an apple, you're not putting out a lot of insulin. And so your body is going to have a better hemostasis. It's going to not send the signal to like, oh my God, store lots of fat.
Yeah.
It's going to say, let's, burn this nicely.
Yeah.
And when you eat something really, a dessert, essentially your liver gets the, instructions from insulin to store. And so you could have, a 900 calorie diet and be gaining weight if you're eating, high
that type of
glycemic index kind of foods.
Wow. I don't know why your description just made me think of like people you invite over to your house for a party, and like some of your guests are going to be really nice and like polite and respectful, and everyone kind of has that like messy friend, and like sometimes they're a really good time, but every once in a while they like mess up your house.
Right.
That's what this all just reminded me of.
Right.
Really strange metaphor, but I'm just sharing it in case that resonates.
Sure. I mean, insulin is absolutely life-saving for people whose pancreas
doesn't produce it.
Yes, especially, the type 1 diabetes, which is an autoimmune, usually follows an enterovirus infection, so a flu-like diarrhea, like kind of, fecal oral virus.
Wow.
And then your immune system attacks your islet cells in your pancreas.
Right.
And for these people, they don't make any insulin. And without modern insulin, they would die.
Right.
So, this is absolutely, it should be free.
Yeah, totally. Yeah. Don't get us started.
On the other hand, too much insulin for many, many years causes type 2 diabetes.
Wow. Again, the delicate balance we keep going back to. Yep.
And they need insulin to, after a while, their islet cells are so burnt out from making, and also their end tissues, because of all the insulin it's had, doesn't respond to the insulin quite the same way. Yes, it'll store the fat, but it doesn't drop the sugar levels down. So, literally your red blood cells have like little hard sugar crystals on it, irritating the walls of your blood vessels and, causing inflammation and things like that.
Wow.
So your body becomes sort of a junkie for the insulin in a case like that. It's like this vicious cycle where you have more and more insulin, and then you're gaining more and more weight, and you're also, becoming more and more insulin resistant. And so you need more and more of this insulin. So, the newest medications are helping people get rid of, adipose and really focusing on, bringing down the insulin levels.
Would that be something like metformin?
That's a really wonderful old-fashioned one. The newer ones, like Saxenda, most people who use them, they'll lose weight because of the way that they're engineered.
Wow.
Which is nice. I mean, they're still newish medications.
Right.
And
so we're kind of waiting to see how things go.
Yeah, exactly. Yeah. At any rate, insulin is a very important hormone to balance. And that's the number one thing, I think, if you get those levels under control, a lot of the other sex hormones will come.
Right. There is like a link, right? There's a link between insulin and your sex hormones?
Yes.
How does that work?
Good question.
In like 30 seconds.
Good question.
Right.
Metformin, which is a medicine that sort of kind of makes the insulin that you have last longer, kind of like Prozac makes your serotonin last longer.
Right, like a reuptake inhibitor.
Exactly.
Okay, got it.
And the metformin basically, is used as a ovulation-inducing agent for people because you stop. Basically, when you make a protein from the pancreas, it's like a ticker tape, and there are splicing areas.
Okay.
And so, whenever your pancreas ejects an insulin, it also injects something called insulin-like growth factor.
Okay.
And this is a really important growth factor when you're a child and going through puberty and things like that. But as we age, lots of that make us grow in the wrong direction.
Right. Okay. Yeah.
And so if your insulin is lasting a little bit longer for your, imperfect diet, you're not making all that extra insulin-like growth hormone, which can mess up the sex hormone
Okay.
Like cascade as well.
Okay.
Yes,
Cool.
Exactly.
Okay. So they are linked. So even if we're talking about, balancing hormones as it pertains to like female sex hormones, menstrual health, these other ones can sometimes be a factor as well.
Yes.
Okay. So this is good to know just for context that this is a pretty broad and, as you probably have gathered from this talk, very intricate topic that is really hard to address in a 30-second to 3-minute video on social media. Important context to have as you scroll through. I'm just putting that out there.
And it's also very hard for a physician to convey this kind of information
in a short
appointment.
Yeah. What's your average appointment time?
Well, I'm special.
I know. I'm like, it's an hour with me. I like coming to you with like a notebook of questions.
They're supposed to be 15 or 20 minutes.
Right.
But I don't like that pace. And so I do more like half-hour appointments.
Well, thank you for always going overtime with me. Well, this is how we ended up having this kind of conversation and why I want to share your wealth of knowledge with everyone else. You've helped me understand kind of the basics of those female sex hormones. Could we maybe break down a little bit of okay, estrogen's basic function is blank and progesterone kind of does blank. I know that's very, very dumbed down.
Oh, golly. Yeah, no. They do so much.
So many things.
Like estrogen. Okay. Should we talk about bones? They're absolutely, men and women have estrogen for bone health.
And we all have testosterone, which technically is considered a male sex hormone, but we're all working with it.
Yeah. Women have much, much lower levels of it.
Right.
But going back to bone health, a man who doesn't have has an estrogen receptor problem will have osteoporosis and mental retardation.
Wow.
So they need estrogen in little amounts, So bones, the estrogens are obviously important for,
living,
changing, giving us breasts and secondary sex characteristics.
Right.
And it's very important. It's the happier of the two female hormones.
Okay.
If you think about the days after your period is over, that's usually the great days. And that's pretty much very, estrogen, very low levels of estrogen, but just the best kind of days for most women.
Okay.
Very little progesterone at that time.
Okay.
And then as, about 14 days after your period has started, a woman who's ovulating normally will have a LH surge.
Okay.
That's the pituitary. Exactly.
Okay.
The pituitary makes that peptide hormone. There are sort of hormone sensors in the brain that sense, certain level of estrogen, et cetera. And with that surge, which is what the ovulation predictor kits are essentially looking at, it makes the follicle release the egg.
Okay.
Then progesterone becomes the hormone that sort of predominates.
Okay. The one at the wheel.
Yeah.
Okay.
And it's progestation. Progesterone.
Oh, that makes so much sense now. I never thought about it that way.
So what does progestation do? Well, it raises our body temperature slightly.
Okay.
Sort of stops us from having, we're starting to incubate something. It thickens the cervical mucus. You don't want any extra stuff going up into your reproductive, now that you're, in your progesterone part of the cycle.
Okay.
And it also slows down our GI motility, our gallbladder motility. So people are more likely to have gallbladder attacks during this time of their cycle.
Okay.
They're also starting to PMS, which is the progesterone.
So
hormone.
progesterone is the PMS one.
Yes.
That's why we don't like it as much.
We don't like it as much.
Yeah.
Yeah. I mean, that's my personal opinion.
Yeah, for sure. And I think you're coming from a very educated place on that topic. So.
It's also been given this in social media and also advertising and, radio stations will be like, oh, use estrogen cream to balance your hormones. And it's just wrong.
Yeah.
I am not a fan of the topical progestins, and I've seen, basically you want to get the ovary to do the right thing for you.
And that doesn't happen with a cream.
It does not happen with a expensive cream that someone is making a lot of money off of that is not FDA approved.
Right.
So
a very good warning.
Yes, exactly. So and then what happens is if you're not pregnant, the feedback loops going on in your ovary kind of poop out, and you stop making all of the hormones, and you kind of go through a hormone crash or withdrawal.
Yeah.
And then your cycle usually starts like 12 to 24 hours later.
Okay. So the drop off is right before menstruation.
Yes.
Okay.
And it triggers the loss of that endometrium that the estrogen and progesterone create.
Right.
And the balance of estrogen and progesterone, the endometrium, the way to think of it is sort of like estrogen makes the grass grow taller and taller and taller, and progesterone sort of weaves it and stabilizes it, helps it get, what are called, these glycogen molecules that would be food for the sperm as it heads on up.
Okay.
And then be a good place for a pregnancy to land. And if you disrupt that, say with a birth control pill where you're not having all those glycogen, and you're not having, a thin mucus and things like that would help you get pregnant, you're bypassing that.
Okay.
So
that's how that works. So just random question about progesterone. Let's say like if someone does have a hormonal imbalance and they have really, really high progesterone levels, like higher than normal, would that indicate they have more PMS or like dysmenorrhea?
It's difficult to say.
Okay.
We usually look at a good progesterone surge as a sign that everything is working well.
Oh, okay. That's good to know.
And for example, if I have a couple that's trying to get pregnant and I do a progesterone, we have these cutoffs. If it's a progesterone in that second half of the cycle, usually about 7 days after ovulation, we don't call it day 21, usually day 21 or day 23, sometime in there. If that level is over 3, then you're very unlikely to grow like endometrial cancer or have problems. We consider that ovulatory.
Okay.
If you're trying to get pregnant, we sort of aim when we're stimulating things for something around the level of 13 to just even show us that everything is working and sort of, juiced up.
Okay.
When the levels are like 50, the patient may already be pregnant or, so that could be a good thing.
So you're looking at these levels and these numbers to kind of see like where the body's at, what it's up to.
Yeah, just like HCG levels when women are pregnant, you can kind of tell how far along things are by them.
Okay.
And actually progesterone is one of those things that can tell us, when it's an early pregnancy, if it's a normal pregnancy or possibly not normal, in other words, an ectopic or a miscarriage.
Right. Interesting. Okay, so we've gone over like the two main ones, but there's also, I guess we talked a little bit about FSH and LH. Then there's also AMH, right? Anti-Mullerian.
Yes.
So I kind of know when we look at that, but for anyone listening who's like, why is my doctor looking at my AMH?
Boy, I wish more scientists were looking at AMH.
Yeah.
So AMH is a really, really interesting hormone. Very important when we're looking at, basically it's a surrogate for how many eggs you have.
Okay.
And very high levels can be an indicator of an ovarian tumor. Mm-hmm. If you have an ovarian cyst that's very weird looking or a tumor, that's sometimes one of the tumor markers,
Okay.
is that hormone.
Right.
So we're born with a certain amount of eggs. Actually, we've lost half of them by the time we're born that we had in utero. And we're losing about half of them again by the time we're in puberty. And they're basically, this hormone called anti-Müllerian hormone is something that a cluster of cells in your ovary called a follicle make. So a follicle is basically an egg that is sort of arrested in meiosis. And it's like Lightning McQueen. It's we were talking about race cars earlier.
Yes.
It's basically got the pit crew around it.
Okay.
Helping it to be healthy.
Cute.
And that pit crew contains these granulosa cells.
Okay.
That theca cells and granulosa cells. And the granulosa cells make this anti-Müllerian hormone. And if you have a lot of really healthy follicles, a lot of race cars, a lot of Lightning McQueens, and a lot of granulosa cells that are healthy, you're going to have a nice AMH level.
Okay.
And so, the levels will be, 10. And then as we age, that level goes down.
Right.
Other things can adversely affect it temporarily. And it used to be that absolutely we thought, boy, men have it so much better than us. They can just keep recreating their
storage.
their storage, and we're stuck with what we've got.
Yeah.
But there's been some data that there is some regeneration of the ovaries that can occur.
Wow. That's hopeful.
Which is very exciting.
Yeah.
And definitely women ask for this test. It's part of the protocol before you do egg freezing. And in my opinion, it's a lot better to do egg freezing when your AMH is at a higher level, 4 or above, because that means you have lots of eggs. And in that $10,000 cycle that you're going to do, you're going to get a bunch of eggs.
Yeah, you want to maximize.
You can get 20 of them,
Wow.
right? Versus if you wait till you're 36 and your AMH is 2, maybe you'll get 3 or 4 eggs that will be possible to,
Right.
and then it's not just the quantity is low, but the quality goes down as we age. So the AMH is a really fascinating hormone. It's also an indirect marker in polycystic ovary syndrome.
Right.
It's not part of this Rotterdam criteria about PCO that basically do you have excess testosterone, acne and hair growth and things like that.
This is actually a good time to bring it up because it is something that I wanted to ask you. Polycystic ovarian syndrome, polycystic ovary syndrome affects as many as 12% of women in the United States, according to a stat I read recently. Has that been an increase? Are you seeing more people come into your office with PCOS, or is this just we're getting better at identifying this imbalance in women?
I'm not sure about if it's more common. I think
diagnostic increase.
Certainly, it is a piece of the puzzle in the obesity epidemic.
Okay,
and it is. So with that getting worse, I would assume that yes,
increase in numbers.
But it's hard to know. Is it like is it a problem itself, or is it a marker of something?
Is it a symptom?
Deeper?
Right.
Yeah.
Okay. Well, it's interesting because then there are patients who may not have any issues with weight who come in and are diagnosed with the same thing.
Oh, for sure. Yeah.
So let's talk about what is polycystic ovarian syndrome. This is really another popular topic about hormonal balances. That Rotterdam criteria you were talking about, the markers. How can someone identify this or, consider that they might want to go see a doctor for a diagnosis?
Yeah. So the biggest 2 criteria are basically we call it oligomenorrhea or infrequent menses. So if you are having cycles that are lasting more than 35 days, then that is telling us that your ovary is not doing a great job of releasing an egg that month.
Right. Okay.
And then the other cue is hyperandrogenism, or basically having signs of too much testosterone, like compounds. So that would be things like acne and coarse hair. And, for some women, they can be much more severe, deepening of the voice, and even things like clitoromegaly. So,
wow. Yeah.
that is a rare, extreme of the hyperandrogenism. But, if a woman comes into the office and she's not having, a regular cycle like that, we'll look at her thyroid hormone, because that's really important. Again, back to more hormones. That's a peptide hormone made. Well, the TSH is what we're testing. We're looking at actually not the hormones itself. Usually we're looking at the proxy for it, which is how hungry is the brain for the thyroid hormone. And so if your brain is very hungry for thyroid hormone and your thyroid glands are not making it because of inflammation or, other reasons.
Insulin resistance? No?
Yeah, no, it's usually an autoimmune thing. The thyroid is a super duper sensitive
organ
for autoimmune stuff.
Okay,
and it is the most common autoimmune issue for women.
Wow.
And that's why we start checking for it when women get early perimenopausal and menopausal.
Interesting. Okay.
So then the other thing we think of, if it's not a thyroid issue, is the polycystic ovary syndrome.
Okay. So it's like the second thing on the list when someone comes in and is like, I'm not good.
Yeah. I mean, in some ways, the thyroid hormone's a lot easier. It's like, oh, okay, here's some thyroid hormone. But for PCO, it's a little more difficult because, there's, it's not, necessarily... because it's not correlated with immediate bad effects, the way that the thyroid deficiencies are.
It's a little more subversive.
And some people say like, ugh, it's, people grow out of it. It's not that big of a deal. Well,
it also presents symptoms in different ways, right? Like not every patient will present with the same condition in the same way. Like we were talking about how you can present with weight issues, but you could also present with zero weight issues. Does that make it more difficult to diagnose?
Yeah, not necessarily.
Okay.
Again, the weight thing, it's hard. It's not a social judgment or anything.
Right. That's an important
And so
note.
it's a delicate thing to, discuss with people, and some people, have this assumption that PCO can only happen if you're overweight, and that's not true.
As we both know.
Something I tell people about, and often when those symptoms present and we do some lab work that's suggestive of it, and one of the big things that's suggestive of it is that we call it the LH-FSH ratio.
Okay.
And so if your LH at the beginning of your cycle is a lot higher than your FSH, 2 or 3 times the number, because they really should be about the same. They should be like 10 and 10. But if like one is, 20 and the other is 10, then that's sort of like, raising your eyebrows like,
red
wait
flag.
A second. Yeah, there's something going on, in the hypothalamus pituitary that's making the ovary not behave properly.
Right.
And as I alluded to before, you can sort of grow out of it. A lot of these women are not going to be terribly fertile in their 20s, especially untreated. But when they get into their, late 20s and 30s, a lot of times we'll do an AMH test and they have a very nice high AMH. So IVF, they're going to have eggs for that.
That's really exciting.
So, I joke, you're banking your own eggs. It's not the worst thing in the world.
Your own freezer in your body. That's actually really hopeful information, because I think until recently, women diagnosed with PCOS lived in fear that they could never have families. They could never naturally conceive a child. Mm-hmm. So to hear that, maybe waiting a little bit longer might be to your benefit is really wonderful news.
Yeah.
So,
we're fine.
Yeah, we're fine. This is fine. Everything is fine. So that's one of the more common, I would say, talked about hormonal imbalances on social media. And I bring this up to you because there is the trend of people trying to balance their hormones at home. Have you heard of this? Is this brand new information to you?
I guess it's kind of brand new. I don't know how they would know other than having a nice regular cycle off the pill. Yeah.
My question exactly, because I'm thinking which is high and which is low, and how do you know, and how do you rebalance? And I guess if you're getting constant blood work, you have that information. But from your perspective, is there anything you can do lifestyle-wise to get your hormones into the delicate balance how they're supposed to be?
Yeah. It's just like what grandma said, don't snack. And, because a lot of it has to do with how our brain is, the hypothalamus and the brain stress can play a part in a lot of what goes on, health-wise.
I'm glad you brought up stress management, because I think that is, in general, a great health tip.
Yeah.
But knowing...
Oh, for balancing hormones. Yeah, it's like eating clean. It's not really a medical term that we do in medical, medical school and whatnot, but it is a social media sensation.
Right.
And it, leads people down different paths.
Right, because it is so broad, it's so vague.
Yeah.
Like, what does it even mean? And I think finally there is some kind of pushback against it culturally. Like, don't say that foods are clean, because that implies what I'm eating is dirty or whatever. It's like a morally ambiguous kind of thing.
Exactly. I think if I could have, my ballywick, it would be about balancing insulin. That is the most important thing, I think, for having everything else, your immune system, everything else fall into place.
Wow, this is good advice.
And so I think the diet plays an important role. The way that we stress eat, emotionally eat, how eating fulfills all this dopamine that we're totally having surges of never before with all the social media and
starving for
else.
Dopamine all the time.
I get the question all the time, oh, will you check my hormones? And people are on the pill or things like that. And it's well, there's certain things I can check, but sex hormones you cannot check when someone's on oral contraceptives.
Interesting.
What
about
pointless.
the other kinds, like in the arm, the IUD?
Yeah, exactly. Okay. It's kind of pointless, because the way that the hormonal contraception works is to sort of put the ovary on ice.
Right. Okay.
So inherently, when you're on hormonal contraception, which is wonderful, I've said many times, I wish I was, if I was Surgeon General, I would ask all women to use oral contraceptives for 2 years, because it would halve their lifetime risk of uterine cancer and ovarian cancer. And, it would rest the ovaries a little bit. And, I do think it's a net positive, especially when used in women in a young age, when, especially when they're the most fertile and are the least wanting to conceive.
Right.
I think that would be a good thing. But as wonderful as the pill is, it inherently unbalances hormones.
Right.
And one of the big ones that it unbalances that we don't like to talk about so much is testosterone.
Mm-hmm.
Testosterone levels are, if you ever use the pill, they will be changed forever.
Interesting.
And it has to do with something called sex hormone binding globulin, which is a binding hormone made in the liver. So a lot of women, when they want to balance their hormones, they'll come off the pill.
Right.
They'll take, quote unquote, a pill vacation, or they'll use a copper IUD or something that's not hormonal, a diaphragm, condoms.
Yeah.
And
lots of alternatives.
Lots and lots of alternatives.
Right.
And that is, a number one way to, if you want to see what's going on with your sex hormones and with your fertility, is to try off of the chemicals that they definitely have their place.
But they're giving you a false read.
They can give you a false read if that's what you're really interested in finding out.
So let's say that a patient comes to you, they have a hormonal imbalance, whether it's PCOS or something similar. I don't know if there's something similar. I'm just kind of keeping it broad. And they do want to figure out how to balance their hormones. First step, you would say, if they're on any kind of hormonal contraceptive, would be to come off of that.
I mean, again, it's an individual thing.
And this is not medical advice.
And this is not medical advice. Exactly. There's a psychological component as well to that cycle we were talking about, and the PMS and the estrogen. For many women, the pill is sort of a lifesaver as far as emotional health and
mental health,
you know, will keep them, not needing to use, Prozac or
antidepressants, anxiolytics. Yeah.
Exactly.
Okay.
So because it evens, having steady state levels of those sex hormones can be good for some people's brains. Right.
Okay, so if you're not making those hormones, this is another potential benefit of hormonal contraceptives, birth control pills. They can help you with your mental and emotional well-being, which is not something I think we talk about a lot.
Yeah.
And so if you are coming off and taking a pill vacation and trying to balance your hormones, naturally bank for that. Plan to potentially have your mental and emotional well-being disrupted. That's a symptom of withdrawal, right? Like that's not, I don't think people talk about this.
Yes, or acne. Oh my gosh. I had a quarter for every woman who says like, oh my God, I think the pill ruined my skin because when I went off of it all of a sudden, and it's not the pill was ruining your skin.
It's the withdrawal.
The pill, the pill was saving your skin from scars.
Yeah. Interesting.
But, that being said, I think it's absolutely fine to not take the pill for a few months or, even a year. You can, again, our cycle goes month to month. And so, we certainly don't want women having accidental pregnancies.
Right.
And so, the message is to communicate with your partner about what you're doing, to be as careful as possible if that's your goal. But I think if you are interested in balancing your hormones and finding out what's going on with your testosterone, one of the other things that's recently gotten some, more traction in the news has to do with athletics and the pill, and that muscle mass is different if you've been on, and what you'll attain will be different.
Okay.
Because of the lower testosterone levels.
Right.
While you're on the pill.
So there are a lot of pros and cons.
Absolutely.
Right. And just stuff to keep in mind. Informed consent, I think, is really important. Talk to your doctor and ask, if someone is coming to a doctor with no health literacy, and that's not to say you're not smart, you just don't have a medical background, try to ask as many questions like, what are the pros and cons? How will this affect me if I decide to not take this or have this in my body one day? Like, these are really important things, especially if you are concerned with hormonal balancing. And we just brought up something like if you are going to come off of some kind of hormonal medication, you're going to have to expect a withdrawal period. It's going to affect your skin. It's going to affect your mood. It's going to affect your period. And then you're going to want to go into some blood work and other things like lifestyle changes, perhaps. So it's not like a, black and white, super easy, cut and dry thing. This is a process. And it's probably really important to have a doctor supporting you, right?
Oh, sure.
Yeah.
Yeah.
And you're like, duh.
Yeah.
Girl.
Well, women are usually pretty good about getting in to see their doctor regularly, which
That's
is good.
true. It's
much better than men.
Pulling teeth with my male counterparts usually to go.
Yeah.
Which is so interesting.
They don't believe in the preventative maintenance.
Yeah. Women are really proactive in that way. I mean, look at the wellness industry.
Mm-hmm.
That's another
topic.
Well,
and we're the perfect consumers.
Mm-hmm.
We're the ones who are in the households, the ones responsible for all the buying decisions, the brands and everything
Which
else.
is how we get to, I'll buy that estrogen cream. Oops. So that's why we're having this talk. We want to make sure that you are more health literate, more science literate. You feel more empowered and equipped. You can go into a doctor's office with your questions, have the informed consent, and feel a little bit more in control of your health. Dr. Marshall, this was such an important talk. Thank you for sharing this. Is there anything else that you wish more of your patients knew about their hormonal health, birth control, menstrual health?
That's a great question.
It's so broad, too.
It's very broad. I don't have a perfect answer for that. Everything's evolving, and as far as, recommendations of how often you see your doctor, and there's been a huge sea change with COVID and whatnot.
Yeah.
But I do think it's important to have a well-credentialed person on your side. I think it's unfortunate that physicians are more and more limited in how much time we can spend with a patient, and still get through the day. And then I see people not getting the answers that they need or think that they want, and sometimes going to less educated
alternative sources,
right. and then being led astray. And so I think it is important to have a good relationship with I believe in complementary alternative medicine, absolutely. But I do think it's good to have your feet on the ground and
your team captain.
To have, yeah, exactly, someone to. And then I highly recommend when you do see them that you have written out your questions ahead of time. You can even hand it to them so they can read it while you're talking to them, because it's difficult. I try to have empathy for my own healthcare providers, and just understand that not every question can be answered, and that a lot of times the answer is very simple that they'll give you simply because of time constraints.
Right. That's so hard. Well, this is really good context. Thank you again. So there you have it, folks. In our next episode together, we're going to talk about hormonal birth control, the treatment of different gynecological and hormonal conditions, cycle syncing workouts, fertility, and postpartum changes. If those topics are of interest to you, hit the subscribe button, sign up for notifications, and we'll give you a little push when that episode is locked and loaded for you. Until then, thank you so much for being here with us. I hope you learned a lot, feel a little more hopeful about your health, and have some tools to take better care of yourself. If you liked today's episode, please leave us a review on whatever platform you're listening on right now. And if you have a topic request, question, or want to learn more about something, send us an email at imfine@thisisfinepodcast.com. All right, go spread your magic, you beautiful humans. Thanks for tuning in to this episode of This Is Fine. I've been your host, Dominique Michelle Astorino. We're based in San Diego, recording in studio at DLI Productions in Pacific Beach with Emmy Award-winning sound designer Dan De La Isla. This is a comedy and advice podcast, but for legal reasons, this entire podcast is a joke and none of it is medical advice. To download the transcript or learn more, visit thisisfinepodcast.com.